Today we're going to focus on two really big buckets of treatment. So we have our immune checkpoint inhibitors that we'll cover for the first half, and then we're going to have kind of like an oral cancer therapy review for just solid tumor focus. Now, of course, I got 55 minutes to go through a lot of material, and so yes, I can't cover every single drug in that time frame, but we're going to cover some basics and hopefully help you guys and set you guys up for success in whatever practice setting you practice. So let's talk about the FDA approval timeline for the different immune checkpoint inhibitors that we have available. So back when I was a wee little pharmacy student in 2011, that is when our first immune checkpoint inhibitor was approved, and that was the ipilimumab. So I actually got to experience ipilimumab treatment during my residency. As soon as I finished residency is when really the fun started, where we got approvals for pembrolizumab and nivolumab for melanoma. Fast forward a couple years, we see atezolizumab, avelumab, durvalumab, and then cemiplimab. And then we had a couple-year break, and this year we have another guy on the market, and that is dostarlimab, which we will cover all of these and what their targets are. So some basics about immune checkpoint inhibitors. We have our T cell and we have our tumor cell. So your T cell expresses the CTLA4 and PD-1. Your tumor cell expresses your PD-L1. So tumor cells, and this is how I explain it to patients, are tricky little suckers, and they find ways to hide from our immune system or shut off our immune system essentially. And they do that through these checkpoints. Super smart scientists have discovered if you block these checkpoints, our immune system still remains active. So drugs that target the CTLA4 is ipilimumab. That's the only one we have FDA approved for that. Our PD-1 inhibitors include cemiplimab, nivolumab, pembrolizumab, and dostarlimab. And then finally, our PD-L1 inhibitors include atezolizumab, avelumab, and durvalumab. All of these have different indications, and we'll talk about that. So our CTLA4 inhibitor, ipilimumab, we talked about what it targets, but when you're talking to patients, they don't understand, or most of them don't understand what a T cell is and kind of explaining the immune system processes. And so when I'm talking to patients with education, I say it's kind of like releasing the brake on the immune system. So it allows your immune system to be more functionally active and kill those cancer cells. The PD-1 inhibitors, again, target that PD-1 on the T cell. Our PD-L1 inhibitors target the PD-L1 on the tumor cell. And so for this one, when I go to talk to patients about it, because it's a little bit more specific and it has, again, a different toxicity profile, and we'll touch on that, if they are age appropriate, use my Harry Potter reference, where I say, essentially what these drugs do is they remove the cloak of invisibility, which means that your immune system can now see those cancer cells. If they're not age appropriate for Harry Potter, then finding some other way to say that you unmask or uncloak or unhide those cancer cells. So with all of these different drugs, all different drug companies have their own drug on the market. And with that in mind, I kind of call it the game of clones. So there's many different agents. There's lots of different manufacturers that involved. I'm personally the Stark fan, any Game of Thrones fans. GSK is the recent one on the market with the dostarlimab indication. But again, there's all sorts of different ones on the market and can be very overwhelming in terms of keeping up with indications and who might qualify for what. So very recently, I discovered this website from the Cancer Research Institute that helps to kind of put together when, as you can see, the indications on the top, so the indications that these drugs are indicated for, and then a timeline of when different indications happen by the FDA. And so the one limitation I did find with this does not include ipilimumab. I'm not sure why, but they only included the PD-1 and PD-L1 drugs. But if you look, for example, in the row way over here, esophageal cancer, really in the past 2 years is when we've gotten most of our indications for esophageal cancer. So for example, you can see these are Nivo, and Pembro indications. With this website, if you go to it and you hover on this dot, it will show you the exact indication. It also gives you some data of why it got its indication. And then finally, it actually gives you what clinical trial led to that approval. And so when you know, not all of us necessarily have niche patient populations that we take care of, especially our fellows or residents. And so hovering over it, you'll see maybe what checkpoint, or excuse me, what checkmate trial might have gotten the approval for that specific indication. So I really found this website to be very interactive and helpful to help navigate and remember what, you know, keynote or checkmate trial helped to get those approvals. So let's talk about the drugs in a little more detail, because of course I'm a pharmacist and that's what I love. So ipilimumab, there's a couple different dosing strategies. The most common ones are the 3 mg per kg or 1 mg per kg every 3 weeks for 4 doses. So you will see that built in a treatment plan, what indication will qualify. Now you might notice in, for example, melanoma, there's actually both dosing strategies listed. And then again, you're just going to follow what standard or what your primary provider wants to do for that patient. A very intriguing dosing strategy that's coming forward is a 1 mg per kg every 6 weeks in combination with nivolumab that is continuous dosing. And so I don't believe we're using this yet at UW, but I believe in the next couple of years, you might see this dosing strategy used for different indications. There's really no renal or hepatic dosing adjustments. If there is some sort of lab abnormality during treatment, then you're going to follow guidelines for what to do with that, and we'll talk about that in a little bit. Toxicities from CTLA-4 inhibitors, you know, in general, I would say it's pretty well tolerated. There is some concern, of course, for those immune-related adverse effects, and we'll cover those. Your PD-1 inhibitors, looking below at the dosing strategies. So Pembro and Nivo have a variety of different dosing strategies. All are flat dosing. You still might see some mg per kg dosing used, but for most indications now we have flat dosing that's approved and built within our treatment plans. The pembrolizumab can be nice because eventually you can sometimes flip a patient to an every 6-week regimen, which, you know, of course helps to save chair time, but also helps to prevent the patient from having visits. And of course, you know, during this time period, we're worried about COVID and the pandemic. Having patients less frequently here can be nice for some patients. Nivolumab, there's different dosing strategies. The 2 most common are the 240 every 2 weeks and 480 every 4 weeks. The 360 every 3 weeks is a new strategy that's used within the esophageal cancer realm. Cemiplimab, I've really only seen within our squamous cell carcinoma population, and I think, I'm going to be quite honest, I think Dr. Bailey's the only one that's been using this. That one's a flat dose every 3 weeks. And then dostarlimab does a very interesting where they do more frequent dosing every 3 weeks for 4 doses, and then they space it apart afterwards. This drug, I will say, is not on our formulary here at UW. When it first came out, we talked with the teams that would be primarily affected by it. And it's kind of like a Me Too drug or a Me Too, and there's already drugs that cover those indications, and there is no need to add this to formulary at this time. Okay, moving on to the PD-L1 inhibitors. That's the atezolizumab, durvalumab, and nivolumab. Looking at the dosing there, atezo is every 2 or 3 weeks. Most commonly, I see the every 3-week dosing. Durvalumab still does have a mg per kg dosing strategy that can be used. And then there is a flat dosing that can be used every 3 or 4 weeks. That exact dosing strategy would depend on what the indication is. And then finally, the avelumab is a flat dosing every 2 weeks. Now, for both PD-1 and PD-L1 inhibitors, they have very long half-lives. They're, you know, a monoclonal antibody, so they're going to stick around in the body for a while. Toxicities we're going to talk about in a little bit. There's really no drug interaction specifically with any of these targets. The one thing that you have to take into consideration, though, is if a patient maybe has a history of prior autoimmune conditions, especially if that autoimmune condition is not well controlled. Okay, so this is where the fun starts, where we manage those immune-mediated adverse reactions, because essentially if you're allowing an immune system to be more active, those can happen. I love this picture. It's about 5 years old now, but I still find it, really tells us exactly what can happen with these therapies. So essentially any organ system can be affected by an immune checkpoint inhibitor. There are organ systems that are more commonly affected versus others. So for example, we'll focus on rashes and skin because that's more common compared to, for example, something that happens in the blood. But I like to kind of go back and, talk about, yes, these therapies are very well tolerated, but what is the, toxicity profile and what percentages are we looking at? So if we specifically look at melanoma treatment, way back when, IL-2 was like our only immune-based therapy. IL-2 was offered at the place where I did residency, and it was awful. It was kind of like feeding gas to the immune system, and patients had to be admitted to the ICU. We do not do IL-2 therapy here. I believe Freighter and MCW might still offer it, but it has been many, many years since I've seen a patient actually receive this. If you look at the percentage of patients that have a grade 3 or worse toxicity, it was 85% of patients in clinical trials. Now, in 2011, when ipilimumab was approved, that number got significantly better, and it's more efficacious. So about 26% of patients have a grade 3 or worse toxicity. Then we got even more particular and more targets with our PD-1 and PD-L1 therapies, and that number decreased to 15%. So we got better, and the toxicity profiles got better, with the really nice part of having a better efficacy. And then finally, we thought, well, let's combine ipilimumab and nivolumab. And when you do combine those therapies, you do see that grade 3 or worse toxicity increase to 55%. Now, I will say that 55% is using a dosing strategy with higher dosing ipilimumab. So it's the ipilimumab 3 mg per kg IV every 3 weeks in combination with nivolumab 1 mg per kg every 3 weeks. If you look at like vice versa, and you look in different disease states, if you have an ipilimumab dose of 1 mg per kg and nivolumab dose of 3 mg per kg, that grade 3 toxicities does appear to come down. So just those doses sometimes do matter in terms of what percentage of grade 3 toxicities can happen. I love pictures. This is toxicity profile photo from, after we had a couple years of using ipilimumab from nivolumab, and it really has not changed with adding more indications. So as you can see from the graph, rash is usually the first thing that can occur, usually a little after 3 weeks. So if you think about that timeline, that's usually after a second dose. And then it seems to taper off and decrease by a little after 10 weeks. Then you have the risk of diarrhea and colitis happening after that. After 6 weeks is when both the liver toxicity and hypophysitis can happen. And so looking at that timeline, the hypophysitis risk, and especially just any thyroid issue, really does not seem to decrease over time with these therapies. And then the liver toxicity does seem to decrease around 14 weeks. The risk seems to decrease. Now, with having experience with all the different PD-1 and PD-L1 therapies, we've discovered that those therapies can have a different toxicity profile compared to the CTLA-4. So if you look at the table B, the PD-1, PD-L1, you still have, the skin rash, the colitis, the liver, the thyroid, endocrinopathies that can happen. But then additionally, these therapies potentially have the risk of pneumonitis. And then further in their treatment course can have the risk or see the risk of nephritis. So those are two things we really did not see often with ipilimumab single agent treatment. When you combine both therapies, all toxicities are kind of on the table, and then they're just heightened, so the grade seems to be worse. And sometimes you might see things happen earlier. So for example, the rash risk when you use combination therapies usually occurs faster with combination therapy compared to single agent therapy. So monitoring. I pulled this data from the NCCN guidelines, and in it, it contains what we should be monitoring when for all immune checkpoint inhibitors. Now, it's a project that's currently happening now. You might notice our beacon plans across different disease states are not the same in terms of what they monitor. So, for example, some treatment plans still have amylase and lipase added as just routine monitoring, but really per NCCN guidelines, we don't need to be monitoring those anymore unless the patient has symptoms. So you might see some plans not have it, some plans do, but if you see it in a plan, just know that you technically do not need to monitor those, and just check or touch base with the primary provider if it's something that can be removed. Again, we're trying to get better, consistent monitoring across the board, but that will be happening within the next year. So we do have clinical practice guidelines. I've mentioned the NCCN guidelines. Those are updated the most often. So they were just updated March of last year. And really they, they're a consensus-based guideline, but they do take into consideration the most up-to-date information with these toxicities, which is good because if you think about this evolving treatment landscape and getting more indications and more experience with these drugs, we only discover so much during clinical trials, but then things pan out over time of how to best manage these. We have UW guidelines here, but again, they probably have not been updated for 2 years. So if there's a place to go to for most up-to-date information, I would recommend the NCCN guidelines. Okay, let's go through 2 patient cases before moving on to the oral cancer therapy section. So MJ is a 66-year-old female with a newly diagnosed metastatic melanoma. She presents to clinic for initiation of ipilimumab and nivolumab. Her past medical history is not significant. She doesn't have any autoimmune diseases. She has a couple different surgeries that she's had. She does have an allergy to sulfa. She gets a skin rash and she's intolerant of aspirin. She has a great performance status. Her medication list is nothing shocking, some allergies, fish oil, sertraline, and vitamin D. Now, MJ starts treatment and she presents prior to cycle 3 of ipilimumab and nivolumab. The previous week during a follow-up phone call with myself, she'd reported a mild rash on her upper chest. We managed it with topical hydrocortisone cream and occasional use of diphenhydramine just for some itching. Today, though, she reports that rash has been increasing in size and it remains extremely itchy. So in her assessment by Dr. Albertini, there's a few scattered areas of rash on her upper chest, abdomen, arms, and upper thighs, which they estimate it to be involved with about 15 to 20% of her body surface area. Body surface area for anything dermatologic matters. So why am I focusing first on skin rashes? Well, it appears to be the most prevalent immune-related adverse effect. All therapies are really implicated and can cause issues. And it's something that can happen in the first couple weeks of treatment, which, nothing is worse than when a patient gets a couple weeks of treatment and they don't call in to report that they have some sort of skin rash developing. And then they show up with, 100% of their BSA affected by a skin rash. The most common is the maculopapular rash. And we do know that if we have early recognition that there is some sort of skin toxicity happening, we can kind of nip it in the bud at that time, get it under control, and therefore it doesn't affect the patient's future treatments. So I talked about the BSA, or I mentioned BSA matters for this toxicity. And so based on anytime you have an immune-related adverse effect, you need to grade it, and that's going to tell you kind of what to do. And so looking here at our chart, you know, less than 10% of a body surface area is grade 1, 10 to 30 is grade 2, greater than 30 is grade 3. And then really when it worsens, you know, at any sort of severe rashes, you're going to consider those a grade 4. So anytime that I'm on a phone call with a patient who's on these therapies and they tell me they have a rash, I try to use the rule of 9 and estimate what percentage of body surface is affected, because it's going to help to dictate what we're going to do for treatment. So I don't know, can I see the chat box? The first question I have is, what grade of toxicity is MJ experiencing? Oh wait, there's the chat box. Anybody in the audience? Yes, grade 2. Thank you, Lauren. That is correct. So looking at the NCCN guidelines, this was actually, I had to update this slide for this presentation because they've changed how they managed, and we've discovered over time that we can help, or we can limit the amount of like oral steroids we use for routine treatment of maculopapular rashes. So if you look here in the far left, you have the different grades. In the middle kind of contains what to do, and then on the far right, it says kind of what you can do with that immune checkpoint inhibitor, because of course that's going to help. You know, that's the first thing a patient asks, because it's like, what you going to do with it. So with her, with MJ, she's grade 2. You technically can continue ICPI therapy, but sometimes it might be beneficial depending on like how the rash looks. Or if you have concerns that the patient might not be like adherent to topical creams, to hold it for a week just to assess where it's going to head. So looking at what we do, you're going to use topical emollients, oral antihistamines, medium to high potency topical corticosteroids. We'll talk about topical therapies. And then if it's responsive to topicals, you can initiate prednisone at 0.5 mg per kg. This used to be higher dosing a couple years ago, which we've discovered we don't need as much. And so that is why it's 0.5 mg per kg now. The question I did have in the guidelines too, and something that we struggle with, is how, when you do have a grade 2 toxicity, how fast that you can taper the steroids. Again, most of these toxicities require a very slow taper, but they didn't actually list it out for this one, but I'm still assuming you're going to probably do it over at least 3 to 4 weeks. Grade 3 or 4, that's when you might see that steroid dose increase, even up to 2 mg per kg if you have no improvement after initial like 1 mg per kg dosing. And at that point, if you see any grade 3 or 4 toxicities, you really need to consult your dermatology colleagues. Okay, so in the UW guidelines, we have this beautiful table that has the potency of the different steroids, and then what steroids qualify as different potency steroids, what strengths they come in, and the different dosage vehicles. So if there's creams, lotions, gels, ointments, a lot of times you're going to want to use a cream or a lotion because it's a lot easier for a patient to apply. So she's diagnosed with grade 2 ICPI-induced skin rash. We did hold ipilimumab and nivolumab for a week. We started other supportive care medications. The patient at that time wanted to avoid oral steroids, which is perfectly fine. She feels that she doesn't feel well on them, and we use topical steroids. So the question is, though, what should we use? So based on MJ's grade of toxicity, which therapy would you recommend? Clopidogrel cream applied twice daily and oral hydroxyzine. Diphenhydramine topical cream and oral diphenhydramine as needed. Hydrocortisone cream and diphenhydramine as needed orally for itching. And then finally, triamcinolone 0.1% cream in addition to hydroxyzine as needed for itching. What are your guys' thoughts? Yes, the correct answer is D. So triamcinolone 0.1% cream is the most appropriate strength. We're just going to go back a couple of slides. So 0.1 is technically a medium, which, oopsie, You can use a medium to a high potency for a grade 2. It also does come in like a lotion, which can be very beneficial because sometimes bigger jars of that can be more difficult to get for patients. Clobetasol, the first answer, is not correct because that's an ultra high option for topical steroids. Okay, so she presents back to clinic 1 week later. Her rash continued to worsen, unfortunately, and she woke up with some new facial edema and erythema. She now has disseminated maculopapular rash, approximately covering half of her BSA. And she's now diagnosed with grade 3 ICPI-induced toxicity. At this point, you really should get your dermatology folks on board. I know we have some new oncoderm physicians who have been wonderful to work with. You should look at their med list and rule out other things. You know, there are some drugs that can lead, some oral drugs that can also lead to rashes. So making sure the patient didn't start anything new. You probably do need some biopsies at some point, but again, your dermatology folks really help to navigate that scenario. But now she's grade 3. What would be her best treatment option? So A and B. A is continue ICPI therapy and admit for IV methylprednisolone. B, continue therapy and admit for PO prednisone. C is hold ICPI therapy and admit for IV methylprednisolone, or hold, option D, hold ICPI and admit for PO prednisone 0.5. So yeah, answer C, I think, is the most appropriate for this. Technically, D could also be correct, but in a patient that that worsened with some topical steroids, I would always err on the side of starting at the higher end of the range versus the lower end. Because if you're going to hold ICPI therapy and admit her because of the significant increase, at that point, try to hit it hard right away. So she presents back to clinic 1 week later. She's doing well. We have a prednisone taper. Again, these tapers usually are really long for patients, so you have to like write it out for them. Make sure they have appropriate supportive care meds. So for example, on this patient, she's a sulfa allergy. So for PJP prophylaxis, you'll have to find something else besides Bactrim. And then of course, continue topical therapies and any anti-itching oral options. Okay, so let's shift gears into patient case number 2. So BG is a 50-year-old male with no significant past medical history, has PD-L1 positive metastatic gastric cancer, so was started on pembrolizumab every 21 days. He presents to the ED after his 4th treatment. He has nausea, fatigue, and abdominal pain. His labs reveal the following. So he's a normal bilirubin, but he has an elevated ALT and AST. So at this point, this is where in the guidelines, Jackie has a question. Can you please repeat grades 2 through 4 skin reactions based on BSA? Jackie, I'm not quite sure I understand your question, so I might have to do that one at the end. But moving back into hepatitis, looking at the different grading, it depends on how many times greater than your upper limit of normal your AST and ALT are. If there's any bili involvement, that's a different section, so make sure that you follow if the bilirubin is elevated. Kind of tells you what to do. Consider holding for grade 1, hold for grade 2, hold for grade 3, and then for any grade 4, you're going to permanently discontinue the therapy. The grade 3 and 4, that's a new update in the past year. They've kind of separated it out more of when this therapy can actually be permanently discontinued. With hepatitis, most often you're going to, with the grade 3 and 4, you're going to initiate steroids again. Steroids, again, are a lot of the backbone of treatment for these therapies. And then if there's no improvement and you're monitoring the enzymes, that is when you could consider, and you do use that word mycophenolate, which I've seen that occasionally used in our patients. The thing with this is the drug infliximab should never be used for hepatitis. They call that out numerous times in the guidelines. Okay, so question, according to NCCN guidelines, which of the following best describes the initial recommendation for grade 3 hepatotoxicity? So continue immunotherapy and monitor liver function tests every 5 days, hold and administer corticosteroids, hold and administer infliximab, or D, permanently discontinue and administer IV steroids. Yeah, the correct answer is B. Oh, you guys got that. You're gonna hold and you're gonna administer steroids. So the patient has grade 3 ICPI-induced hepatotoxicity, you're gonna hold, you initiate prednisone. This can be done in an outpatient setting, but then the patient does need to monitor their LFTs. The guidelines say every 1 to 5 days. We're usually like at 2 to 3, every 2 to 3 days it seems to be. And then taper that prednisone over 4 to 6 weeks. So my experience with immune checkpoint inhibitors, I have a story that really, kind of affected how I practice and why I find that pharmacist involvement with these therapies is important. So a 58-year-old patient was found down by her husband. She was unconscious. She was sent to a local hospital. She had a 14-day hospital stay because they couldn't quite figure out what was going on with her because there was a delay in a diagnosis of DKA and adrenal insufficiency. So this was when I was back at the Mayo Clinic in Arizona, and the patient was being treated with pembrolizumab. The really unfortunate thing with this scenario is the patient was extremely private and she didn't want to burden her family. So her family did not know that she was actually on this therapy, and she had nothing on her that identified her to that she was on pembrolizumab. The local hospital was not connected to our cancer center. So they didn't have, way back when, gosh, you sound so old. Way back when, they didn't have care everywhere that we could look and see, oh, she's actually on, pembrolizumab. There was this long delay in identifying the patient with ICPI therapy. She was really critically ill for many, many, many days. And she was actually diagnosed with a new onset of type 1 diabetes and adrenal insufficiency. Little did they know, or they finally figured out that it was caused by the pembrolizumab. So because of that situation, it really affected me. When I moved to UW 5 years ago, we built our immune checkpoint inhibitor. And so pharmacists in clinic, we insert ourselves, especially on the days where patients are receiving the therapy. So we do a little more education with the patient so that they really understand what to watch out for. And we provide them with a wallet card that contains what drug that they're on, who their doctor is, what side effects to watch out for, and when to call, and then the phone numbers to call if somebody discovers the patient or if there's any questions of who to report to. We then follow up with patients at specific time points. So for example, we'll follow up with them a week or two after their first treatment just to see how everything is going. The phone calls are really, really quick, but we've actually discovered that when we do this in clinic, the pharmacists are actually identifying the majority of the toxicities, especially things such as like the skin rash or any GI issues. Of course, ones such as like LFT elevations or hepatitis, we can't monitor that through a phone call, but it's kind of been a cool program over the past almost 4 years. Have had over 350, this might be closer to 400 now, patients enrolled. And so you'll see our notes in the chart that we've been following up with the patients consistently. So my final immune checkpoint inhibitor thoughts, I could spend hours talking about immune checkpoint inhibitors, but anyways, a couple things. Now, a new paradigm shift in treatment options is we have immune checkpoint inhibitors plus different either chemotherapy agents or targeted agents. And so sometimes it can be hard to tease out what drug is causing what side effect. So I think we're in this now new treatment paradigm where we're going to have to get better at identifying that. Some things are easy, but some things can be a little more difficult to tease out. Some disease states have preferences for what ICPI therapy they're going to use, because as the game of clones, some drugs have the same indication. And so your primary DOT teams have kind of picked which ones they want built as treatment plans. And then there's 2 treatment plans to call forward. This first one, 60-43, is actually like a blanket indication for all solid tumors that are MSI high. And so that is a treatment plan that you might see in a patient. It doesn't have their specific disease state, but is again that blanket indication. And then this bottom one here, 8298, is the pembrolizumab every 6-week dosing. So if you're going to switch a patient over to that, you have to use this treatment plan, and this treatment plan contains all the different disease states that pembrolizumab every 6 weeks can be used for. So I wanted to call those two things out for when you guys are starting to navigate and begin. So with that, I'm going to move right into the